Hello, ladies and gentlemen. Welcome to Triple N Media. I am Dr. Nik Nikam. These cardiology seminars are brought to you by Triple N Media on our YouTube channel. We have more than 180 cardiology lectures, which you welcome to watch. And please do subscribe to our YouTube channel. And the featured presentation for this seminar is going to be heart failure laboratory tests. What kind of tests do we order, and what are the significance of each one of these tests that we order? So let's take a complete look at all the tests that we might order and see how they can help us in diagnosing the extent of the heart failure and what we need to do after that. Of course, all of these patients are going to get electrocardiogram. Electrocardiogram can tell us a lot of information about what's happening with the patient's heart in terms of heart rate, in terms of heart rhythm, in terms of ectopic beats or arrhythmias like atrial fibrillation or atrial flutter. There may be evidence of conduction disturbances, cardiac enlargement, and SGT changes that may suggest ischemia. So an electrocardiogram is very vital, and not only do we need to get an electrocardiogram, but compare it to the previous electrocardiogram on record and see what are the new changes we are seeing compared with the old electrocardiogram. The next is chest x-ray. As a cardiologist, I strongly believe in chest x-ray. A lot of people don't, but if you look at the chest x-ray, you can get an overall impression of what's happening in the lungs in terms of infiltrates, atelectasis, fluid, pneumonia, or pulmonary edema, and cardiomegaly, and also maybe calcifications. Next is lung ultrasound. I don't do lung ultrasound very often, but intensivists may do it to look for evidence of a fluid or anything else. Echocardiography. Echocardiography can be done in the intensive care unit at the bedside if it's available, because there are a lot of places where they have this compact echo machine where you can quickly take a look at the left ventricular size, left ventricular function, and left ventricular ejection fraction to give a quick overview of what's happening with the heart as we are trying to diagnose whether the patient has congestive heart failure, is this cardiac, or is the pulmonary edema related to something else. Of course, the biomarkers like BNP, pro-BNP, and MRANP are quite useful in trying to rule in or rule out acute heart failure. If the BNP is less than 100 picograms per ml, you know you're not dealing with congestive heart failure. Similarly, the pro-BNP, if it's less than 300, you know you're not dealing with a heart failure patient. So right away in the emergency room, you can easily make a differentiation between pulmonary edema related to left ventricular failure versus pulmonary edema which may be related to some other cause like infection, or it could be some reaction, or it could be volume overload. Okay, serum troponin is very useful, especially when we are dealing with the coronary artery patients, because let's face it, 90% of the patients with heart failure may have coronary artery disease, and it helps to see if we are dealing with an ischemic event, especially if it is associated with EKG changes. Then we can put all the pieces of the puzzle and find out what brought this patient to the hospital to begin with, if the patient had chronic stable heart failure in the past. Serum creatinine is exceedingly important in not only diagnosing what's going on with the kidneys, but also in terms of determining the cardiovascular drugs and adjusting their dosages based upon the serum creatinine level. If there has been a significant jump in the serum creatinine from like 1.5 to 3.5, you know what brought the patient to the hospital. It's probably worsening renal failure, complicating heart failure. Serum electrolytes are without a question important, especially potassium and magnesium. Many places they don't check magnesium. I would routinely check magnesium level. If the magnesium level is low, I would give intravenous magnesium to bring the level above 2. Then iron. Iron is looking at any evidence of iron depletion, which can be suggestive of slow bleeding, because a lot of these heart failure patients are on blood thinners, and we always need to think about blood loss when they come in a decompensated state. And here are some of the other tests which are going to be helpful. Thyroid, elderly patients, many of them are on thyroid pills. They could still be hypothyroid, so checking the thyroid level will help us to determine how well their thyroid is functioning. Has their hypothyroidism been corrected? If not, we can adjust the dose of the thyroid hormone the patient is getting. D-dimer. If you suspect the patient is having an acute onset of shortness of breath with minimal changes on the X-ray, and you suspect blood clots like pulmonary embolus, D-dimer might help you, but it may also complicate things, because if you get a borderline test, then you have to make a decision as to how you're going to rule out pulmonary embolus. Do you need to do a more definitive test, like giving contrast, which may not be the right thing to do if the patient has kidney problem. Procalcitonin is useful if you are not sure the infiltrates that you're seeing are related to heart failure or due to pneumonia or infection. However, procalcitonin may be elevated only in cases of bacterial pneumonia. If you're having a viral pneumonia, I don't know if it's going to help you very much. Lactate level may help to identify acidosis, because patients with heart failure have low cardiac output, they have low perfusion, and as a result it's very easy for these patients, if they develop arrhythmia or if they develop hypotension, for them to develop lactic acidosis. And if you're dealing with low perfusion, then we have to make every effort to improve the cardiac function and cardiac index. A pulse oximetry is a quick way to find out how well the peripheral circulation is doing. If the oxygen saturation is 80, then you know the peripheral circulation is poor. That means this patient has poor peripheral circulation. And arterial blood gases may not be necessary in every patient if the oxygen saturation is okay, and if the patient is able to lie flat or in an upright position, and if the patient responds to diuretics and medical treatment, we may not need a blood gases. But however, if the patient has history of chronic COPD and you're not sure how much of this is related to the heart, how much of this is related to the lungs, and arterial gases might help us to identify hypoxia and also elevated carbon dioxide levels. So in summary, this is a quick review of most commonly done tests, lab tests. In the emergency room, it can be done, and then we can decide what needs to be done as far as treatment and further testings. You have been watching Triple N Media, and please do subscribe to our YouTube channel, where we have more than 180 cardiology lectures, all basic science lectures, which will help you in terms of your board preparation. And this cardiology seminar is brought to you by Triple N Media, and I'm Dr. Nik Nikam, and we will see you next time. Thank you so much.